Medical Director, Biopharmaceuticals Medical Unit, AstraZeneca Pharmaceuticals in Delaware. So give a big hand to Dr. Vendito.
Well, thank you again for the invitation to come back and speak. It's been always, I look forward to it at the meetings. I'm an interventional cardiologist by training, and so that goes to show that you don't have to be a heart failure specialist and an amyloid expert to really get into and understand amyloidosis. So what I'd like to do for the next 30, 40 minutes is go over what is becoming increasingly a more timely topic. And I think you see that reflected in the agenda at the major heart meetings, and today at AHA and yesterday too. And even tomorrow morning, I think there are a few more sessions and lots of posters on amyloidosis, and specifically for the cardiologist on transthyretin amyloidosis. And so that's what I'd like to speak to you about and talk to you about the disease state itself, the etiology, the epidemiology, and the clinical manifestations, and then talk a little bit about the treatment of this disease, which is relatively recent in development, and also talk about what's in the pipeline and new treatments for ATTR. So the underlying cause of ATTR is the formation and deposition of amyloid fibrils in the body, and TTR protein is the culprit. Okay, so amyloidosis in general is just a protein misfolding disorder. It could be any protein misfolds. In the misfolded conformation, it forms monomers and fibrils and deposits in tissues. And so amyloidosis in general is a systemic illness, and that's especially true of TTR amyloidosis. And so what you see really depicted here is the formation of TTR, which is predominantly in the liver. About 95% of TTR in the body is made in the liver. Some of it is in the GI tract, and some of it is in the choroid plexus in the central nervous system. It's a different amyloid that is associated and indicted in Alzheimer's disease. It's not TTR, but nonetheless, TTR protein is made on the other side of the blood-brain barrier in the choroid plexus. And as you can see here, there's TTR formation in the liver, and there are two main types of TTR amyloidosis. There's the wild type form, and basically it was formerly known as senile amyloidosis, and again, not Alzheimer's, but senile in the sense that it tended to occur in patients in their 7th and 8th decades. And we still have no idea why amyloidosis that is structurally normal, why the TTR protein dissociates, forms monomers, and forms amyloid. And we'll go into it in a little bit more detail, but wild type is very interesting, and we'll talk about it now, and then the rest of the discussion will really be focused on hereditary. But if you do an autopsy on octogenarians, almost half of them are going to have evidence of TTR amyloid deposition in tissues, but very few of them are going to have the clinical phenotype of amyloidosis. And trying to understand why patients will deposit TTR protein as amyloid in their bodies in the wild type configuration, and why some will develop cardiomyopathy and systemic manifestations and others don't, is still a mystery. Wild type has that in common with hereditary transthyretin amyloidosis, which is really what we're going to focus on going forward. So you can see that there's a gene and gene mutations, and there are maybe 130 now recognized mutations in the TTR gene that lead to an abnormal amino acid sequence, therefore abnormal folding of the protein, and then the protein itself is a tetramer. It has 4 subunits. And if the protein is in normal structure, those tetramer units, the subunits will hold together, there's stability, and the TTR protein will go about doing its job, which is in its name, transthyretin. So it transports thyroxine, and it transports retinol. Now, the body can figure out other ways of transporting thyroxine, but it is pretty dependent on TTR protein for retinol. And as we'll see, that has some consequences with respect to vitamin A, perhaps. So the tetramer is unstable when there's a mutation. As I mentioned, there are about 120, 130 recognized mutations. There are maybe a half dozen that are common around the world, and in particular in the US, and we'll go over that. But what they all have in common is that the tetramer dissociates, it's unstable, It forms monomers. The monomers then form fibrils, and the fibrils deposit then throughout the body. So it's technically a rare disease. Hereditary ATTR is a rare disease. And as we'll see in a moment, there are two main phenotypes. There's a polyneuropathy that's associated with TTR amyloidosis, and there's a cardiomyopathy associated with it. But those are two of the extremes in phenotype. Remember that this is a systemic disease, and you'll understand its clinical presentation and also the difficulties in diagnosing it, but it is a systemic disease. So there are approximately 2,200 patients diagnosed with hereditary ATTR polyneuropathy in the US. And I'm sure that the true prevalence is much higher than that. Oftentimes, as we'll see, it's misdiagnosed, or the diagnosis is simply attributed to an idiopathic process. There's a lot of undiagnosed ATTR polyneuropathy. There's even more undiagnosed ATTR cardiomyopathy. And that's where, as cardiologists, we really need to think about how many patients in our practice right now maybe fall into this phenotype and could potentially have undiagnosed ATTR. And so what you see here, for example, is a population, 13 to 17% of patients with HFpEF. So HFpEF is not really a diagnosis. HFpEF is sort of a phenotype, right? What is causing the HFpEF? What is causing the diastolic dysfunction and the restrictive cardiomyopathy? And oftentimes these patients will have plausible explanations. They'll have hypertension, they'll have diabetes, and you may not go much further down the differential for causes of their HFpEF. But one of the main causes is potentially ATTR. And in retrospective studies, we've seen that 10 to 15%, and in some studies even higher, 17% of patients with HFpEF have underlying undiagnosed ATTR cardiomyopathy. And that has consequences because this does not behave as garden variety HFpEF. It carries significant morbidity and mortality, particularly if it's untreated. Likewise, as I mentioned before, about 10% of adults greater than age 60 with carpal tunnel will have amyloidosis. They'll have deposits of amyloid in the tenosynovial tissues. Now, they could be carriers. In other words, they may have amyloid in their tissue at carpal tunnel surgery, but that doesn't necessarily mean they'll develop the clinical syndrome of amyloidosis. Again, one of the unknowns in this disease state. Why do some patients with amyloid in their carpal tunnel biopsy have amyloidosis, go on to develop the syndrome, and why others don't is really not well understood. It's not standard of care across hand surgeons around the US, but there are pockets of hand surgeons who are now very much aware of this and are doing biopsies routinely in patients undergoing carpal tunnel. Now, the reason is that about 50 to 60% of patients who have amyloidosis had a prior history of carpal tunnel. And typically it's bilateral, and typically it doesn't improve with surgery. It comes back. Now, carpal tunnel, we're thinking nerve impingement. It's not the neuropathy per se, but rather the extrinsic compression of the nerve in the earlier stages. And as we'll see, in terms of the timeline, it develops years before the actual diagnosis of amyloid. For those patients with PN or CM, about 1% of the patients will have an underlying diagnosis of TTR that needs to be made. And then for TAVR, right, again, plausible explanations for a thickened myocardium, aortic stenosis. And so for patients undergoing TAVR in retrospective studies, what we've seen is a good percentage of them, and again, 10 to 15% in some trials, have underlying ATTR cardiomyopathy. So it can disguise itself and hide, and it is typically very difficult to diagnose. These are the systemic manifestations, right? So hereditary ATTR can impact basically any organ system and all organ systems in the body. And it's really recognition of this constellation of signs and symptoms that's critically important. Now, if a patient came into the emergency room complaining of everything that's on this slide, you would think they've got some significant systemic disorder, and what's in your differential then? And amyloid would be one of those things. But as we'll see, it's not that easy and not that simple, because each of these manifestations, though they're systemic, are presenting over time as this disease evolves. And each tissue seems to have a different tropism for the amyloid, and the symptoms related to amyloid deposition in various systems throughout the body will evolve over time differently. So this constellation evolves over years, and that's what makes it a little bit more difficult to diagnose, because you need that perspective. In retrospect, it's easy, but as it's evolving over the course of 10 to 15 years, it's a little more difficult to focus and pull this phenotype in. Let me actually go over this in a little more detail. How do I go backwards? Here we go. There. So the polyneuropathy, and it's PN stands for polyneuropathy, and that's important because a lot of people jump to peripheral neuropathy, think we need to call a neurologist, I can't find my reflex hammer. Polyneuropathy, I think, is something that falls within the realm of a cardiologist, because part of the polyneuropathy is not only the peripheral neuropathy, small fiber involvement initially in the distal lower extremities, sensory and motor evolving over time, and that's the classic pattern of the peripheral neuropathy associated with ATTR. But there's also a dysautonomia that's a big part of it, and the dysautonomia can be fairly prominent. Now, as cardiologists, we're used to dysautonomia. We're used to orthostatic hypotension. We're used to abnormal endovascular function. So I think that the cardiologist can recognize that in a patient and then recognize those aspects of the polyneuropathy and feel comfortable understanding that the nervous system, the peripheral nervous system, is involved in this disease. The autonomic symptoms typically is orthostatic hypotension. The autonomic symptoms are systemic, and they could involve the GI tract, so bowel motility is affected. And very commonly, these patients will have early satiety, they'll have diarrhea, they'll have constipation. And these are prominent and pretty typical symptoms for these patients. They'll have sexual dysfunction, they'll have bladder dysfunction. Again, they may, as you'll see, go to a GI specialist, a gastroenterologist, and come up with an idiopathic bowel disorder. They may see the urologist and have no real explanation for what's going on. And it's difficult in retrospect, easy in retrospect, but difficult as the patient is presenting over time to piece it all together. The musculoskeletal symptoms are prominent. So we mentioned carpal tunnel syndrome. Patients, particularly with wild type, may have lumbar spinal stenosis. Again, as I mentioned, about 50% of patients who have amyloidosis, ATTR, had a prior history of carpal tunnel syndrome. Now, if you look the other way, what percentage of patients with carpal tunnel syndrome end up having amyloidosis? It's less than 1%. It's much lower. But it is a red flag nonetheless. Musculoskeletal symptoms, spontaneous bicep tendon rupture, multiple joint replacements, particularly with no real explanation. This is something that's kind of typical, and as cardiologists, sometimes we don't sit down and take a thorough orthopedic history. But again, in review of systems and history, I think it's important, if you're suspecting a systemic illness particularly, to take a thorough review of systems and start to bring this picture out. Now, I mentioned for the GI symptoms, there's constipation, there's diarrhea. The diarrhea can be so limiting in terms of lifestyle. Oftentimes, patients are no longer going out. They're not leaving the house because of the diarrhea they're experiencing due to ATTR. Nocturnal diarrhea is sort of a red flag. And now focusing on the heart, right? This is typically a patient presenting with diastolic dysfunction and HFpEF, with a restrictive cardiomyopathy. That's the typical cardiac phenotype. And as I mentioned before, that's not a diagnosis necessarily. You need to understand what drove that, what's the underlying etiology. And as I said, because there's hypertension or diabetes, there's a plausible explanation. Oftentimes we stop there. But really, it's the differential diagnosis for that phenotype that we need to consider and include ATTR cardiomyopathy in that differential. Patients will typically then have HFpEF. They'll have heart failure with preserved ejection fraction. But this is not garden variety HFpEF. If you do the hemodynamics, very often these patients have low cardiac index, 1.5. They're virtually in cardiogenic shock. They have very decreased exercise tolerance. They're intolerant to standard heart failure medications. If you've got really severe diastolic dysfunction and you're not so good at filling your heart between systoles, you're going to, in order to maintain your cardiac index, increase your heart rate because your stroke volume is so limited by the diastolic dysfunction. Put them on a beta blocker and their cardiac index plummets. They needed that heart rate. And that's a telltale. That's a red flag. It's sometimes not the way you want to make the diagnosis, but it's a red flag clinically. Also because they have the dysautonomia and the orthostatic hypotension. They have very little preload reserve. You give them afterload reduction, preload reduction, their volume status is very tricky to manage. In essence, they don't have a Starling curve, but more of a Starling spike. So managing their volume status and their blood pressure and hemodynamics is not all that simple. And also another red flag with respect to hypertension is a hypertensive patient who suddenly gets better. Again, because of the dysautonomia and the orthostatic hypotension that they develop, their hypertension will disappear and they no longer need medications. That's a sign, especially if you were thinking that hypertension was the cause of their HFpEF and their diastolic dysfunction. So they typically will have this intolerance to guideline recommended therapies. They'll typically have atrial fibrillation. About 70-75% of patients with ATTR cardiomyopathy will develop atrial fibrillation. And then rate control can be an issue, again, for the reasons we just mentioned in terms of controlling their heart rate. Conduction abnormalities, there's direct deposition of amyloid in the conduction system. So it's not uncommon for them to have high-degree heart block and require a pacemaker. Ventricular arrhythmias are also seen in ATTR cardiomyopathy and increase the risk of sudden death. And of course, then there's peripheral edema, right? The hemodynamics are what you would expect in really bad diastolic dysfunction. So I mentioned earlier that there's probably about 125, 130 now recognized mutations in the TTR gene that result in hereditary ATTR amyloidosis. Now, some of them are very common, relatively speaking, compared to the other mutations, and we really recognize the clinical syndrome that's associated with them, but the majority of them are variants of unknown significance. There are so few of them, we really haven't had a chance to study these small numbers of patients and really characterize the phenotype that goes along with many of these variants. But the common variants are on the screen here, and they're sort of listed on a spectrum. So what you see on the left is a predominant PN, polyneuropathy phenotype. What you see on the right is those variants associated with a predominant cardiac phenotype. But what you notice too in the purple that's underlying the light blue and the dark blue is that many of these variants, the majority of them, have a little of each phenotype. And of course, underlying all of it is the systemic manifestations, as I mentioned, the GI, musculoskeletal, and the like. So on one extreme, we've got the V30M, which is a very common mutation, one of the most common in the United States. We have the V122I at the other end. Again, it's a false dichotomy, this left and right. And think of all of them as having the potential for mixed phenotype. And I'll explain that in more detail later. And so V30M, early onset, V30M, late onset, T60A, very common also here in the US. And so you may have a patient presenting with cardiomyopathy and heart failure symptoms predominant, and you'll work them up and you'll find that they're at this end of the spectrum. And you may have a patient who's gone to see the neurologist for a rapidly progressive polyneuropathy, and they may need to also be evaluated for the cardiac manifestations. And so you can see here that about 80% of hereditary ATTR patients have some clinical manifestations of both polyneuropathy and cardiomyopathy. And there are some implications of that, and I'll explain as we go forward. So each of these different mutations, variants, do have different characteristics. So the typical age of onset for V30M early onset is early, in the 30s, under age 40. It's also seen very typically in Portuguese populations, in Sweden and in Japan. And again, the mysteries of this disease. If you are in southern Portugal, you present early, and if you are in northern Portugal, you might present late. And the phenotype varies also by the geography. And sometimes the phenotype for the identical variant can vary within a given family. There are studies in identical twins who have the exact same variant who have very different clinical manifestations of the disease. So this is a disease that's exciting and fun because there are far more questions than answers right now as we start moving forward in this field. So what you can see here too is the predominant phenotype, and it varies, as I mentioned, going from a V30 to a V122. Now, there's another factor here, and you can see the different populations that are affected. V122I is the most common variant in the United States. It's associated with cardiomyopathy. It tends to be a particularly bad cardiomyopathy. The morbidity and mortality is the highest for all of the forms of ATTR-CM. It may be because of the population where it's most prevalent, and that is in patients with Caribbean or West African descent. So blacks in the US, about 3 to 4% carry this variant, carry this mutation. That means we have a lot of carriers of this disease, and then there's another factor, penetrance. Not everyone who has the mutation is destined to have the disease. And we don't understand what drives the penetrance of the disease either. But 3 to 4% of African Americans in the US is a large number. And I tell you now that that number, that potential prevalence for ATTR carriers and its penetrance is far, far greater than the number of currently diagnosed V122I patients in the US. So it's a particular form of this disease that is vastly underdiagnosed. And when it does present, it presents late. And that may reflect a lot of the healthcare disparities that affect the population most at risk. And it may not be as virulent a form of the disease as we think. It just may be a function of the fact that they tend to present late in the course of their disease. And of course, the later you present, the greater and worse the morbidity and mortality. And this is a slide just really showing ethnicity, race, and nationality, and how it varies and how it's distributed. It's particularly difficult to study this disease because, you know, a busy center, a center of excellence, an amyloid clinic, may have 50 patients, and that's not a real high number, especially if you want to start studying and drilling down into variables that are affecting the disease. So it's important, and it's a big, important initiative, I think, and we're starting to see it, and it was reported here at the meeting, that we're forming larger registries so that we have larger cohorts and the ability to really start to understand this disease better. So ATTR polyneuropathy, I mentioned before that it's a significant diagnosis to give a patient. It is a fatal disease, it's rapidly progressive, and it's associated with significant disability. These are data from 2 of the large randomized trials looking at silencers in patients with ATTR-PN. This is the placebo group, so it's showing you the natural history of this disease. And what we're looking at on the y-axis is MNIS, which is a measure of their neuropathy. And what we can see in both of these studies, in a matter of 35 and 66 weeks, that this patient's disease in the placebo group has progressed significantly, so that a patient may be walking with difficulty at baseline and could be in a wheelchair 66 weeks later. Significant rapid progression, which is one of the things that distinguishes it from other types of neuropathy. Of course, you'd like to find this patient and treat them when they're near their baseline and best function, rather than making the diagnosis after you saw the so-called red flag that this progressed so rapidly. But clearly, diagnosing this early, treating it early is critically important, because while there may be some return of function, some improvement, no matter when you start treatment, they'll never recover to where they would have been if they'd been treated earlier. This is looking at the effect of cardiomyopathy associated with survival. And so what we see on the left are Kaplan-Meier survival, and it's stratified by genotype. So the dark blue is V30M early onset, the yellow is V30M late onset, and these are the percent survival on the y-axis over years. Again, it is something that develops much slower. The cardiomyopathy develops more slowly than the neuropathy, because the neuropathy, the pathology there is irreversible harm and damage, and ischemic injury and direct deposition in the nerve. In the myocardium, the amyloid TTR, unlike light chain, which is toxic to cardiomyocytes, the TTR is rather inert, and it's basically in the way. So it's filling up the interstitium, causing a problem in terms of heart function, diastolic dysfunction, and infiltrative cardiomyopathy. But it isn't necessarily toxic to the cardiomyocytes. And that's interesting. Understanding that aspect of the disease mechanism portends for some real hope for some treatments that are in the pipeline and coming down the line. So we can see that there's a big difference in terms of survival by genotype. And then I also mentioned that V122I is a particularly bad form. So on the right, what we're seeing is survival curves for wild type, no variant, versus V122I, the hereditary form. And we can see that it's associated with significantly increased mortality. And the time span is in months there. So survival is much less and significantly affected. I don't know how that happened, but let me try this. There we go. All right, so we understand the cause of the disease, misfolded TTR protein. We see that it's a systemic illness. We know that it progresses rapidly. It's a debilitating and fatal disease, especially when it affects the nervous system. These patients are cachectic and wasted and really immobilized very quickly. For the cardiomyopathy, it presents as HFpEF. Progresses also, but it progresses more slowly. But CV death is the leading cause of mortality in patients with ATTR amyloidosis, regardless of whether it's mixed phenotype or pure CM. So I mentioned that, there's the systemic manifestation of this disease, and it tends to progress. And if the patient came in all at once with all those symptoms, it would be easy, but it doesn't happen that way. What we see here in terms of carpal tunnel, you can see on the timeline here that it tends to be about 10 years before someone makes the diagnosis of ATTR amyloidosis. So there's deposition that's been going on for a long time, and over time it accumulates, affects the various tissues, and manifests clinically. So carpal tunnel, total knee replacement, and then the autonomic dysfunction will predate the diagnosis and the more obvious clinical manifestations of the disease, particularly in some of the variants. V122I may have a mild neuropathy and dysautonomia a few years before the heart failure becomes a clinical problem. On the right, we see that about 57% of patients had carpal tunnel syndrome, autonomic dysfunction, biceps ruptured in nearly a quarter, and hip and knee replacements in about 20% of patients, all of it predating their diagnosis of ATTR when they came to the cardiologist with heart failure. These are the typical GI symptoms that we see, and so the vast majority of these patients will have GI symptoms. And it's very common that they'll see 4 or 5 specialists before they finally get their diagnosis of TTR. And in every one of those groups, there's always a gastroenterologist. And inevitably, the diagnosis is, irritable bowel, idiopathic bowel. And it's if you're focusing on one system, and it's the system in front of you, you're not thinking of the whole patient and their past history. You'll see that you're not stepping back to see this constellation. And so these are all of the different symptoms that have been reported very commonly in these patients when they present with ATTR amyloidosis. So this is a typical timeline, right? So a patient sees an orthopedic surgeon back in 2012. They have numbness in their hands and feet, and patients may attribute that to, some ache in their neck or pain in their lower back, a disc. If you don't ask, you don't take the history, you may not get it. Chronic GI symptoms, for years before. Sees the gastroenterologist, reports diarrhea and weight loss very typically, right? There's direct deposition in the bowel mucosa, and there's also the autonomic nervous system affecting motility. And those two things combined result in the symptoms of constipation, intermittent with diarrhea, and weight loss. So the point here is that they've seen their PCP, they've seen the gastroenterologist, they've seen the neurologist, and finally they see the cardiologist, right? And the cardiologist is always the one who makes the right diagnosis. But the cardiologist, has got sort of the low-hanging fruit. This patient's come in with heart failure. And so you go through the normal process of working up the patient with heart failure, but hopefully you don't stop at HFpEF as your diagnosis. You start to entertain what's in the differential. But this is a very, very typical pathway to diagnosis for thousands of patients that have been diagnosed with ATTR. Staggering various symptoms from different systems over many years, seeing several doctors, and basically on average 4 to 6 years of active symptoms where the diagnosis could have been made before the diagnosis is actually made. So how do you make the diagnosis, right? So recognizing that pattern of systemic involvement evolving over years is critical. But now what do we do when we come to the patient? So we've got a PN clinical presentation. They've come to the neurologist with predominantly neuropathic symptoms. And on the right, we've got the patient presenting with heart failure to the cardiologist and the polyneuropathy. And so that should be a flag that if you're thinking this is ATTR cardiomyopathy, the dysautonomia is a sign of polyneuropathy, and the patient needs to be treated accordingly. The neurologist will evaluate the patient, take a history, do a physical. This is a motor and sensory neuropathy that is developing, first involving small fibers. That's why the autonomic nervous system is affected initially. And then there's tingling in the feet and hands, and eventually it moves proximally and involves larger and larger fibers. So sensory, motor, and autonomic dysfunction, that combination should to the neurologist or any of us be a flag. On physical examination, you have the associated findings of some weakness, gait disturbance, and then confirmatory findings. There's nothing that's pathognomonic about the EMG, but nerve conduction studies will be abnormal, right? Skin biopsy for epidermal nerve density. So you can do a skin biopsy and see that those small fibers are gone. They've been damaged, and you can look at the density of small fibers. Not every center is doing this, but centers of excellence, where there's a neurologist interested in ATTR, they'll do this, and it can be very helpful, right, in making the diagnosis. There's dysautonomia, so sweat gland assessment, right, and amyloid, and biopsy. Nerve biopsy is not very sensitive. The deposition of amyloid TTR in nerves is somewhat patchy. And so you can't take a bunch of samples from your sural nerve. There won't be a nerve left. And so oftentimes you may miss the amyloid. And so nerve biopsy is not as sensitive as a cardiac biopsy would be, right? And then, of course, genetic testing. So almost the majority of polyneuropathy associated with TTR is in the hereditary form of the disease, okay? So genetic testing will rule in or rule out ATTR polyneuropathy. There's some discussion and argument. There's a little controversy as to whether or not neuropathy is a component of wild-type ATTR. And there are some that feel very strongly it is, and some that feel very strongly that there is no component of neuropathy in wild-type ATTR. So right now, we recognize neuropathy in the hereditary form, and a genetic test for the TTR variant would help you rule that in or exclude it. And as a neurologist seeing this patient, or anyone, primary care physician, anyone who's made this diagnosis or strongly suspects that this is ATTR-PN, one of the easiest ways to make the confirmatory diagnosis is to do the cardiac evaluation, because the majority of these patients will have some cardiac involvement. If you look at studies that have looked at the reasons why the PN diagnosis is missed in these patients, a negative PYP scan, a negative cardiac workup is one of the strongest predictors of a missed neurologic diagnosis. Because as we'll see in a moment, if you've got the cardiac form, you probably have, and you have a neuropathy, it's likely that that neuropathy, if it fits the description, is due to ATTR. So it's important that the cardiologists get the referral even when only PN is being suspected. These are the things that a neurologist might typically mistaken for ATTR. So patients often with CMT are misdiagnosed as having CMT when in fact they had ATTR. Chronic axonal idiopathic polyneuropathy and CIDP, very common diagnosis given to these patients, where you can see that 13 to 15% actually had ATTR, and 24 to 33% actually had ATTR. So I'm talking about the neurologist, and we're all cardiologists, and you're thinking, great, I'll just get a neuro consult. Good luck. In the US right now, it's about 19 to 1 cardiologists to neurologists treating this disease. So we're at the American Heart Association meeting, and maybe you went to ACC. There's a lot of amyloidosis in the schedule, right? Go to AAN, and you won't see a single talk on amyloidosis. So the neurologist, because the PN form of this disease is so rare, by an order of magnitude, are not really all that interested. So you'll find a neurologist at a center of excellence, at an amyloid clinic, but you may be hard-pressed to find a neurologist in your neighborhood who can help you with this. Again, why it's so important for the cardiologist to feel comfortable in making the diagnosis of polyneuropathy, because you may not find a neurologist around who's comfortable doing that, and often if there is one, studies have shown that you'll wait about 6 to 9 months for that patient to be evaluated. Remember the time scan I showed you before. In 66 weeks, the patients had progressed rapidly. So that kind of delay is critically important to patients. Very often, this neuropathy is misdiagnosed as diabetic neuropathy, and these patients are very different from diabetic patients. There's far more dysautonomia. There's much more motor, far greater than sensory, and diabetic neuropathy is mostly sensory. And this progresses 5 to 8 times more rapidly than diabetic neuropathy. But unfortunately, it is the diagnosis these patients are given most often. All right, now more familiar territory. How does the cardiologist work this up and diagnose this? Okay, so I've said already, they come in with HFpEF, they come in with an echo or an MRI that shows thickening. There's some interstitial process. This is HFpEF, but they're behaving atypically. So they've had some imaging. They've had something to raise your suspicion, and I'll go over that in a second, that this may be underlying ATTR. So the first thing you want to do is send off a monoclonal protein to make sure that this isn't light chain amyloidosis. That's critically important. You don't want to miss that diagnosis. And then the next thing you're going to do, and if it comes back positive and it's light chain, you call the hematologist, right? There's still a cardiomyopathy associated with light chain, but now you're going to manage that along with the hematologist who's treating the light chain amyloid. The thing you do then is order a cardiac scintigraphy, a PYP scan. And this is what makes it so easy for the cardiologist. Neurologists do not have this type of a test. They really need to rely more on their clinical judgment. But we can do a PYP scan. And the PYP scan will be positive if the patient has deposition of amyloid in the myocardium. All right? So if you've got a grade 2 or 3 uptake on a PYP scan, that's consistent with cardiac amyloid. You want to rule out light chain because a positive PYP can still be light chain. Some patients with light chain will have a positive PYP. So it's not pathognomonic for ATTR cardiomyopathy. It's good for cardiac amyloid, and you always need to differentiate. If it's negative, and amyloidosis is unlikely, if your clinical suspicion is high, the guidelines recommend that you do a biopsy. If your clinical suspicion was low and the PYP is negative, move on. They've got something else. If it's positive, the next thing you want to do, now having diagnosed ATTR cardiomyopathy, is to do genetic testing. All right? That's critically important, again, because we want to establish whether or not this is hereditary disease or wild-type disease. And then, of course, you want to send the patient or evaluate the patient yourself to see if there's polyneuropathy. All right, so how did we get into that algorithm? We got into that algorithm because we were suspicious. And we're suspicious because we've done an echocardiogram, for example. And the echocardiogram is going to show biventricular hypertrophy. All right, and so there are different cutoff numbers, but if you see septal thickening at 1.4 or 1.5, and it seems to be more uniform throughout, and you can calculate the ratio of the posterior wall to the septum, and there are different scoring systems for amyloid. But the echo is great at giving you a reason to suspect ATTR. So there's thickening, there's restrictive LV filling, there's marked diastolic dysfunction, the rule of 5s. And then you've got reduced longitudinal strain with apical sparing. That's not, ATTR is not the only time you see that, but those are telltales on the echo. For the EKG, there'll be a discrepancy, right, between the QRS voltage and LV wall thickness. There may be arrhythmia, there may be heart block. Those are things that are indicative. Now, what's interesting is there are a lot of AI models now with machine learning that have been trained on echocardiograms to point out that the patient's echo or even their EKG is consistent with underlying ATTR and give you a nudge that you really need to go further to work this up and do a PYP, basically. The MR will show myocardium loaded with, potentially with amyloid. They'll show thickening of the interstitium. There's late gadolinium enhancement and increased in extracellular volume. Those are, again, not pathognomonic, but they're consistent. And then, of course, bone scintigraphy, as I mentioned, will really give you an answer. So, all right, my computer needs to restart. Thank you very much. So this is what the echo looks like, and on the right is the classic picture of decreased longitudinal strain with apical sparing. So you get that cherry on top, and you see the thickening on the four-chamber view on the left, and then the strain pattern, and then the bullseye with that typical pattern on echo. The EKG, as I mentioned, shows that discordance between volume and then thickening on the echo. This is what the MRI looks like, and MRI and echo may be ways of not only indicating the presence of the underlying disease, but for monitoring disease progression and response to treatment. There really isn't a recognized standard for doing those two things, but MR and echo are the best that we have right now, and are really developing a lot of data that way. And so what you see is no late gadolinium extension on the left, and transmural late gadolinium on the right, which is consistent with underlying ATTR. And then, of course, there's the PYP scan. And so what you see here on SPECT imaging is the uptake in the myocardium, and it's graded from 0 to 3, and 2 to 3 is really considered positive. There's some quantitative methods for evaluating the PYP that are used mostly in research, but what you'll get is a positive scan, and that means grade 2 or 3. That would be what you'll get in the report, and that confirms the presence of cardiac amyloid. Now, SPECT is critically important, and I think at this point in time, SPECT has become the standard, and it's how this is done widely. If it's not a SPECT PYP, the risk of a false positive is really high. And so if it's not a SPECT PYP, it needs to be repeated in order really to conclude that that's the story. And I mentioned this already, that it's critically important that you rule out light chain. And so we've gone through all of this, but this is the pathway to diagnosis. Again, right now, typically, it's delayed by years from when the patient should have been diagnosed with all of the presenting symptoms to when they actually were. A pathway that includes seeing multiple specialists over too long a period of time. So, very quickly, how do we treat this? And currently what we see on the screen right now is the currently approved treatments. And they're a little bit of somewhat of a false dichotomy that's created in terms of label indications currently in the US. And that's because, again, remember the mechanism of action. TTR is the culprit. It becomes unstable, the tetramer dissociates, and then the trouble follows. So one way to treat this disease is to stabilize the tetramer so it doesn't fall apart. And that's what so-called stabilizers do, right? And currently the stabilizers are indicated for cardiomyopathy, hereditary or wild type. In the US stabilizer, right now there's only one, tafamidis, but there will soon be a second. Acoramidis has a PDUFA date at the end of this month and is likely to be approved for wild type or hereditary cardiomyopathy. Neither one of them are indicated for polyneuropathy. So in order to treat polyneuropathy, you need to start a silencer, right? And that's that false dichotomy that I was talking about that's current in the US labels. So the silencers, and it's, with gene therapy on the horizon, silencers make you think we're silencing the gene. What we're doing is shutting down translation, right? So the silencers are antisense oligonucleotides or interfering RNA. So they get to the mRNA that's coding for TTR, enhance its degradation, less TTR protein is made. So you are reducing the amount of TTR that's being made, whereas stabilizers are in effect increasing the amount of TTR that's around, but holding it together. And that's pretty simple, but that's the story. Silencers currently are indicated for polyneuropathy, but not for cardiomyopathy. And that may change next year on the results of a Helios B trial, where we may have a silencer, vutrisiran, indicated for both PN and CM. And then eplontersen is another of the silencers that's currently indicated for PN. And the largest trial in ATTR is underway now, and that's the CardioTransform trial with eplontersen. But that won't read out yet for a little while. But ought to shed some light on some important questions. Now that we can use a silencer to treat PN and CM, or we can use a stabilizer to treat still only CM, what's the best combination? How do you choose? You know, when there's only one drug to choose from, it's pretty straightforward. But now you've got stabilizers, 2 of them, silencers, some for PN, some for CM and PN, and no data, no comparative studies to really guide you in making treatment decisions. So CardioTransform is the largest trial with over 1,400 patients, and when it reads out, the subgroups probably will be powered enough to give us insight into how to manage these patients. And just one last thing that I think is really very exciting and very promising. Remember what I said earlier, that the TTR protein is sort of inert, just sitting in the way. It's sitting in the interstitium between the cardiomyocytes. It's not really damaging them, but it is definitely interfering with cardiac function. So if you think of this problem as a leaky faucet and the sink is overflowing, you shut off the sink. That's a silencer, that's a stabilizer. But now you got this mess to clean up. That's the depleter. So the depleter is a monoclonal antibody that will bind to the TTR amyloid in the tissue and then facilitate the body's removal of the ATTR amyloid. Now, sounds like an interesting concept, but have we seen proof of concept? People were interested and excited, but there was a report by the group out of the UK last year where they reported 3 patients with pretty severe ATTR cardiomyopathy who had spontaneous recovery. Spontaneous recovery clinically, negative PYP scans, improvement in their MR, and spontaneous resolution of their disease. They were found to have an autoantibody to their own TTR amyloid. So if these patients can do it on their own, perhaps a depleter, a monoclonal antibody directed at the TTR, will make a big difference. And frankly, as I said with that crude analogy of the sink, you know, shutting off the water is important, but you've got this mess. And you know, I think that the depleter is going to be really central in the overall recovery for these patients after we've shut down deposition and then cleaning up the amyloid that's deposited. And so this is, you know, early data with the Alexion 2220, and you can see on the PYP over time how a very positive PYP is resolving over time with the depleter. This is improvement in the PYP at 4 months, at 12 months, and extracellular volume on MR at 4 months and 12 months. So the concept is now being proven in these phase 1 and phase 2 trials. We're seeing improvement and reduction in proBNP and troponin and resolution in these imaging studies. And so now it's going to be studied in a phase 3 trial that's ongoing. I know maybe some of you are active sites in the trial, in the depleter trial. And we're really looking forward to the results of this. I think it's exciting. 2220 is not the only depleter that's being developed, but I really think that the depleters in combination, in some combination with a stabilizer or silencer is really going to be the treatment for these patients going forward. And so I'll stop here without going into any more detail on these trials. And thank you for your attention. Projects around the country now to develop the models and importantly implement those models.
Very brief. Thank you. It's an excellent informative presentation. This is very relevant to our research in India. You know, Dr. Naveen is my mentor. We are doing a lot of cardiac research in India for the past 10 years. Currently, we are looking into the specific of COVID. So far as the myocarditis is the buzzword. You know, you said we are specifically asking the question of recent any information of the long-term COVID impact on myocarditis. This is very important for our research in India because the research is not there much, and this being a very rare disease, so your answer will be very helpful to us. And you can contact us if you have more information about the recent information of specific impact of COVID-19 on the myocarditis.
Sure, be happy, yeah. Very interesting. There was just a talk yesterday on dysautonomia in long COVID. in cardiomyopathy, which was very interesting. The group out in Colorado has done a lot of work that way. I talked a little bit about the dysautonomia, but it's one of my pet projects right now because myocardial flow reserve is severely impacted in patients with ATTR cardiomyopathy. And that may be due to the polyneuropathy, and we may deplete and remove, but patients who have markedly abnormal myocardial flow reserve, that has prognostic importance. And if it's the polyneuropathy rather than the difficulty in filling because of the interstitium and the external pressure, that mechanism hasn't been explained, but something else that we want to get at. But long COVID and dysautonomia is something that's been looked at now too.
Thanks very much. Thank you, John. Thank you for coming here. And really
Thank you all very much. Thanks for your attention.
We're exactly on time here. And the next talk is going to be by none other than Professor Raman Puri, would be associated also with Dr. Vinod Vijan, and co-chair my namesake, Dr. Rashmi Nanda, are all both from India. Dr. Raman Puri is one person who single-handed developed the Lipid Association of India, very, very important, and has done a lot of work, a lot of guidelines they have published from India. And as a matter of fact, he's going to say whether does adopting Western LDL-C targets expose Asian Indians to higher cardiovascular risk. And he's going to give his expert opinion on that, which will be followed by Dr. Vinod Vijan. And the co-chair is going to be Dr. Rashmi Nanda, who are all associated with the Lipid Association of India. And Dr. Vijan is really the CEO of a very big hospital in Nasik in Maharashtra. Dr. Raman Puri.
Thank you. Thank you, Dr. Nanda, for kind words. And my topic, if you look into the topic, many of you may not agree to it, but that is the reality. That does adopting Western LDL cholesterol target exposes Asian Indian to a higher cardiovascular event? I'll try to justify my statement. We all know that there is reduction in cardiovascular mortality in United States, and credit goes to AACIO guidelines, and there is a significant decline in cholesterol from mean of 102 to less than 105. But what happens to South Asians? South Asians living in United States still have 3 times more risk of ASCVD as compared to other ethnic group. Let us go to Europe. Significant decline and 17% decrease in CSD mortality in 2011 to 2016. Look at what happens to South Asians living there. 2 times higher ASCVD events. All of them are following European and American guidelines, remember. They are not following LA recommendations. These are all guidelines from the United States and Europe. It's not only USA and Europe. Even if you look into other countries also, Asian Indians have higher cardiovascular mortality. So there is no doubt that we have higher ASCVD event as compared to other ethnic groups. But look at CVD mortality in India. It has gone up by 41% from 1990 to 2015. So there has to be some reason. These are the list of the reasons. Probable reason for increase in CVD mortality and coronary artery disease and associated mortality. And the most commonly discussed is the presence of atherogenic dyslipidemia. Means we feel very happy when we see our LDL cholesterol. And we think that we are absolutely fine. But you don't remember that there is a significant increase in small dense LDL particle because you have high triglyceride and low HDL cholesterol. Another factor, of course, is central abdominal adiposity, which is playing a very major role nowadays. And of course, low control rate of hypertension, hypercholesteremia, diabetes also contribute to it. Poor awareness, not in the public, among the healthcare professionals also is contributing to that. And of course, we love a high carbohydrate diet, more of trans fat, and we love, a sedentary lifestyle. So looking into all these factors, we think that India requires its own lipid guidelines. We understood all this problem in 2014, and it took us about 2 years to formulate the first part 1 of our consensus statement, in which 153 experts were involved, and we published in 2016. Based upon major ASCVD risk factors, other high risk features, and non-conventional risk factors, we classified patients into low risk group, moderate risk group, high risk group, and very high risk group. And we proposed the goals. The LDL cholesterol goal for patients with very high risk group was less than 50 milligram, and those patients with high risk group, it was less than 70 milligram. These goals were 20 milligram lower than the European lipid guidelines. So these were 20 milligram lower. And in 2019, even European, they updated their guidelines and they came out with LDL cholesterol goal of less than 55 in patients with established ASCVD, and the goal of less than 40 milligram in those patients who had recurrence in ASCVD within 2 years. And in 2022, even ACC updated their recommendations, and the proposed goal of less than 55 in patients with high risk group and less than 70 milligram in those who are not in high risk group. But the problem doesn't stop here. If you look into IMPROVE-IT trial and ODYSSEY trial, in IMPROVE-IT trial, 32% of patients, despite achieving LDL cholesterol around 53, they had events in 6 years. And in ODYSSEY trial, 12.5% of patients had event at LDL cholesterol of 53 in 4 years. We are scared of, bringing down LDL to 50 milligram. Remember, we have events even at LDL cholesterol of 50 milligram. We looked into this matter and we came out with consensus statement part 3 in 2020. What we did, we had number of meetings and we proposed a separate group for those patients who have an underlying ASCVD and divided those patients into 2 categories, category A and category B. Category A are those patients of ASCVD who have one or more features of high risk group, and category B are those group of patients of ASCVD who have one or more features of very high risk group. This was based upon a lot of evidence. I'm going to just discuss one of the evidence. If you look into ODYSSEY trial, in ODYSSEY trial, in which the alirocumab was given, those patients who had only coronary artery disease, without peripheral artery disease, no cerebrovascular disease, they had 8.6% event in 4 years. Those patients of coronary artery disease who have either peripheral artery disease or cerebrovascular disease, event went up to 20.3%. And when all 3 vascular bed was involved, it was 26.7%. So I think you will all agree with me that if LDL cholesterol goal is 50 or 55 for patient with coronary artery disease, you cannot expect the same goal to be there for those patients who have 2 vascular bed and 3 vascular bed. This is, I think, gives a very, strong evidence for having different categories in patients with the ASCVD. And based upon this, we came out with another goals. And the goal for patients with category A was less than 50 milligrams, similar to what was in very high risk group. But there was an optional goal of less than 30 milligram because you may propose 50 for that patient, but I may propose 30. So there was a, decision can be either 50 or 30. But in category B, it was less than equal to 30 milligram. And 1 year after our recommendation, National Lipid Association, for their South Asian population living in United States, they came out with a statement. They also created a new risk category of an extreme risk group, and they also agreed with our recommendation of less than 30 milligram in patients, selected patients of extreme risk group. Again, this 30 milligram was not something is imagination. We had a very strong evidence of less than 30 milligram. And one of the most important trial was the 4-year trial in which when LDL cholesterol was brought down to the median of 30 milligram, there was 15% reduction in primary endpoint and about 20% reduction in secondary endpoints. We updated our consensus part 3 to consensus 4 in recently published document in Clinical Journal of Lipidology. And I'm not going to go into the detail. This is the algorithm because my topic is not related to the ASCVD risk stratification. My topic is that why should we have lower goal? Because based upon what I have discussed, the goal of 50 But ALIA has recommended similar goal for the same disease, clinical diseases. European goals are 55. And what we said 30 is 40 of European. So this 5 or 10 milligram difference, is it significant or not for Indian population? So that is what we have to, I'll try to justify. Remember, because I have given you an ample evidence that we have higher events, It's not only we have higher events, we develop premature coronary artery disease. And this premature coronary artery disease is associated with higher mortality. If you look into the coronary artery disease in Indian population, we develop heart disease 10 years earlier than the Western counterpart. And 25% of myocardial infarctions are in those patients who are less than 40 years. And 50% of patients who die of coronary artery disease are less than 50 years. In contrast, if you look into the European population, 90% of the European people who die of CSD are more than 65 years of age. What a vast difference between our ethnicity and the Western population. So this is a very important fact which you have to understand. Whatever now I am going to discuss the points in favor of lower LDL cholesterol. Remember, we develop heart disease, higher prevalence of heart disease, despite our LDL cholesterol level is approximately 10 milligram lower than the Western population. And this is based upon Inter-Heart study, which shows that South Asians have on approximately 10 milligram lower LDL cholesterol as compared to non-Asians. And this is not only Inter-Heart study, UK Biobank data, which is a very large study in which 400,000 European population versus 8,000 South Asians were, compared. South Asian LDL cholesterol goal, the level was around 10 milligram lower as compared to the European population. And even then, they had 2 times higher AACVD events. And so this means, I think you will agree with me that if you have lower basal LDL cholesterol, you require a lower target of 10 milligram. Because remember, the cardiovascular event reduction doesn't depend upon any number. It is how much LDL cholesterol you reduce and how long you reduce, it matters. Now, the best example is the Mendelian analysis, which shows that if there is a lifelong reduction of LDL cholesterol of 40 milligram, then there is about 50% reduction in cardiovascular event in the later part of the life. If there is a 20% reduction, it translates into 30% reduction in events. If it is 10 milligram lower, it translates into 18% reduction in event. And if it is 5 milligram, it translates into 8% reduction in event. So what does it mean? The 5 milligram is important for South Asians. 10 milligrams are important for South Asians because we have high prevalence of coronary artery disease and it is associated with higher mortality. Each milligram of LDL cholesterol matters to us. So this means if we try to have the same target, what Western guidelines recommends, we are going to have higher events equivalent to 5 milligram and 10 milligram of the goal, respective goals. So that is one of the very strong reasons why our LDL cholesterol goal should be lower as compared to Europeans and Americans. Now, after LDL cholesterol, we know that we have high prevalence of triglyceride. Rather, we discuss about triglyceride much more than LDL cholesterol. You will be surprised that only triglyceride, will never cause atherosclerosis. Will never cause atherosclerosis, but it can lay down the foundation for atherosclerosis. It is the cholesterol content of the triglyceride-rich lipoprotein which is responsible for atherosclerosis, not the triglyceride. But if you look into the PROVE-IT trial, even if the patient has achieved LDL cholesterol of less than 70 milligram, those patients who had triglyceride more than 150 milligram, they had significantly higher event as compared to those who had an triglyceride of less than 150 milligram. This is because increase in triglyceride is associated with increase in inflammatory state. It has been seen as the triglyceride goes up, high sensitive CRP goes up. And if you look into the LDL cholesterol, increase in LDL cholesterol is not associated with high increase in CRP. And as you know that inflammation can lead to subendothelial dysfunction that can help in migration of or entry of LDL particle into the subintimal space along with monocytes, initiating the process of atherosclerosis. Now, we all know, have you know what is VLDL cholesterol? How many times you have looked at VLDL cholesterol? I think majority of us will say that no, we don't bother about, we bother about only LDL, triglyceride and HDL. But VLDL primarily, to a great extent, is the cholesterol content of the triglyceride-rich lipoprotein. So you can say it is equivalent to remnant cholesterol. And this is the main culprit other than the LDL cholesterol. So you should always look into the VLDL cholesterol also when you are evaluating the lipid profile report. If the triglyceride-rich lipoprotein cholesterol, or I will now for journal's sake, I'll say VLDL cholesterol is more than 39 milligram as compared to less than 19 milligram, there is 48% increase in cardiovascular event. This is independent of LDL cholesterol. So therefore, higher is the triglyceride, higher is the VLDL. Therefore, it is, you said that the association of triglyceride with coronary artery disease. It is because of VLDL cholesterol, not because of triglyceride. We all know that increase in triglyceride is associated with non-HDL cholesterol. It's very simple. Total cholesterol minus HDL cholesterol is non-HDL cholesterol. At any level of LDL cholesterol, higher non-HDL cholesterol is associated with a higher cardiovascular event. Then we all know that the triglyceride, if goes up, it increases the proportion of small dense LDL particle. If the triglyceride is less than 100 milligram, then 85% of the population have large buoyant LDL particle which doesn't crosses the subintimal space, because to cross the subintimal space, the particle size has to be less than 70 micron. But as the triglyceride goes up, and if it goes up to more than 250 milligram, 85% of these population have small dense LDL particle, and this small dense LDL particle is highly atherogenic. And then increase in triglyceride is associated with increase in ApoB. What is ApoB? ApoB is a protein which every atherogenic particles carries with it. And the only plus point is that each atherogenic particle will carry only one ApoB. So this means if you know the level of ApoB, you can know that how many circulating atherogenic particles are there in that particular patient. So that is a biggest and a strong predictor of cardiovascular event. And this has been shown by inter-heart study and amyloid study that higher is the ApoB level, higher is the cardiovascular event. There is a positive linear relationship between ApoB and the cardiovascular event. This is not right now the primary target. Right now the primary target is LDL cholesterol. I think 10 years from now, everybody will talk about ApoB. LDL will take the back seat. And it is said that if you reduce ApoB by 10 milligram, if you reduce ApoB by 10 milligram, irrespective of whether you reduce it by lowering LDL cholesterol or by lowering triglyceride, it results into 6% reduction in events in 4 months' time. And if it is a lifelong reduction of this ApoB levels, it results into 30% reduction in cardiovascular event. So that means that it is not the LDL cholesterol lowering or a triglyceride lowering, it is basically a lowering to what extent you lower ApoB, which translates into the reduction in cardiovascular event. Then another important part is that when we look into the LDL cholesterol, even if you have achieved the LDL cholesterol to the target, let us say 50 or 55, and corresponding non-HDL, which is 30 milligram, within 30 milligram of LDL cholesterol target, and ApoB, we have defined the number. It has been seen in Indian study which has been recently published that even in those patients in which you have achieved LDL cholesterol target, those patients whose triglyceride is less than 150 milligram, majority of these patients have concordance between LDL, non-HDL and ApoB values. Means they are concordant. But if the triglyceride is more than 150 milligram, it becomes discordant. Discordant means the LDL target is achieved, but non-HDL cholesterol and ApoB target are not still achieved. And in these patients, it is ApoB which is responsible for future cardiovascular event, and you have to be more aggressive in lowering ApoB. And when you aggressively lower ApoB or non-HDL cholesterol, at present there is no selective drug that is going to selectively reduce non-HDL cholesterol and ApoB without reducing LDL cholesterol. So to have the concordancy between LDL cholesterol, non-HDL and ApoB, we require, and South Asian requires lower LDL cholesterol as compared to the Western population. Now coming to the third part of atherogenic dyslipidemia, which is a low HDL cholesterol. We all know, based upon epidemiological study, that 1% decrease in HDL is associated with 3% increase in cardiovascular event. And in UK Biobank study, it has been seen that, not in UK Biobank, other studies also shows that on average, South Asians have 7 milligram lower HDL cholesterol as compared to Europeans and Americans, And so you can understand that lowered HDL will translate into increase in cardiovascular event. But pharmacologically or pharmacotherapy which increases HDL cholesterol has not been translated into reduction in cardiovascular event. Rather, there have been an adverse reaction as is seen in AIM-HIGH trial and HPS2 trial. But we still believe that HDL, which is increased by physiological mechanism like exercise and all that, that will definitely result into reduction in cardiovascular event. But to mitigate the higher cardiovascular event because of low HDL cholesterol, we have no other option than to reduce LDL cholesterol further to reduce the cardiovascular event. Then we all know lipoprotein A, it's a very hot topic nowadays, that we have high prevalence of raised lipoprotein. And it has been seen that if you look into the mean lipoprotein A in South Asian versus European, South Asian have higher lipoprotein A as compared to European. It is 31.2 versus 18.5. We all know that lipoprotein A is pro-atherogenic, pro-inflammatory, and pro-thrombotic. And at present, though, there are few drugs which are going to come in the market shortly, but as present, we don't have any drug which specifically reduces lipoprotein A, again like HDL cholesterol, to counter the increased CV event due to higher lipoprotein A. We have no choice than to reduce LDL cholesterol to a lower value. Remember, LDL cholesterol of 50 milligram and 30 milligram is absolutely safe. It doesn't have any, adverse effect. We have all myths about it. Of course, if it required, we can go for discussion. Based upon all this, even ACC and American Heart Association also consider South Asian as a higher risk, as a risk enhancer. So rest will be discussed by Dr. Vinod Vijan regarding justification, and I'll give his few comments.
Very great talk, very well done. I think Vinod and Rashmi, can you please? Oh, Rakesh, come.
Hello, sir, please.
Yeah, okay. Take a picture. Yeah. Okay. Come, Rakesh, in the center. Yeah. Center.
Excellent, very good.
Okay, Vinod, can you come and give a comment? And also Rashmi, where is Rashmi here? Please come over, come to the front here, and so just 1 minute.
Thank you very much. So, in fact, it is indeed an honor and pleasure to be here along with AACIO. This is, let me tell you, my second attempt and the first successful in coming to Chicago. Last time when I had come to USA and COVID phase struck, everything was cancelled. And that was that Chicago, which was in parallel with ACC. And I was stranded for 3.5 months. So thank you very much, sir, again for your kind blessings, and all the officials of AACIO, and to Dr. Raman Puri and Lipid Association of India. I'm here. See, my job is just to, not only justification, take home points. So just to sort of summarize, I feel I am like that in the Hindi movies which you see, the last scene when the hero has bashed and killed 50 villains, rescued the heroine, And then the police comes in the end saying, भागने की कोशिश मत करना. अभी भागने की जरूरत क्या? He has already killed them. So that's my job. And so I will try to do justice, but give you a very important point to ponder, over which you will have to think. That is, would be, I suppose, the key message. So what is the justification for need of the Indian guidelines? Believe me, sir, LAI has come a long way. We are now known not only here, but it is for the first time the Asia Pacific Society of elite Asia Pacific Rim, of which we were not members, had asked for an invite in India, and we had our national LAI conference along with the Asia Pacific. And that shows the growing importance of understanding the lipid values. And all the elite people, all of you know that in spite of being in America, still those Indian diaspora or the Indian, those who are genetically, have 3 times a higher risk. And we will discuss even in that. So in India, the cardiovascular mortality has increased despite decline in the European and US itself, but that does not include the Indian population. Please understand that. ASCVD events have increased even among Indians, as I've alluded to earlier, despite following the respective guidelines. What is important is that we South Asians develop heart disease not 10, but I would modify 10 to 15 years earlier than other ethnic groups. That's a known fact. And it is much more severe in us and carries a higher mortality and long-term prognosis also as compared to non-Asian countries, despite having lower LDL-C levels. And to have the same benefit of cardiovascular event reduction, we should have a LDL-C goal of 8 to 10 milligram as compared to the Western targets. And even if your LDL-C is achieved, aggressive additional treatment is necessary to achieve non-HDL-C and ApoB, about which we have just discussed, and treatment to achieve this target will further lower LDL-C, since there is no specific treatment to lower non-HDL and ApoB. And one should achieve all the 3 targets for LDL, non-HDL-C and ApoB for treating all the patients of Indian dyslipidemia, as we have seen that cutoff of triglycerides up to 150, and if it is still beyond, then think of other drugs maybe to reduce triglycerides. And South Asian ethnicity, unfortunately, all of us here, is a risk enhancer even in the ACC guidelines. And that is why we need our own guidelines. So my plea to all of you is that now that we have got so much of data, and now we are even so proud that AACIO, along with the blessings of Dr. Nanda and all of you, have sought an affiliation with LAI, why don't we start together to form a risk factor calculator for the Indian diaspora, for the Indian subjects, whether they be in India or they may be settled outside, because the risk is 3 times higher. And nowadays, with the aid of artificial intelligence, it is much more easier. And I would request that we should start working on this. This will be even useful to you, because then you can justify to your insurance companies that you require still lower levels of LDL, which can be reimbursed, which otherwise I believe would be put into a question, that you already attained the US guideline. Why do you want to increase the drugs or reduce the LDL lower? So this is my suggestion and plea to all of you. And we would be here. Let me tell you, today we have even embarked on multiple studies, like our triple combo has got the best award.
Be available during dinner, so if you have any questions for them, you can ask them at that time. Okay. In the meantime, what I'll do would be to ask the young investigators, because that's our most important event of the day, is a presentation from the young investigators, and maybe they should come up and load their slides here, if all of them who are present. In the meantime, we have one other very important event to do, and that is to honor some of our cardiologists who are here. The first one we have here is Dr. Sanjay Bindra. Please stand up and come over here. So please, give him a big hand. He's a cardiac electrophysiologist. But I'll tell you an interesting story. We had come here last night to just check out the restaurant here. And the waiter who was serving us mentioned to me, "Are you a doctor?" I said, "Yes." And he said, "Do you know Sanjay Bindra?" And I said, yes. And I said, why are you asking his name? Because he said he has established a foundation and he has helped many students from India with funding to come out to this country. So I think that is the best thing I can talk about you, Sanjay. Very good. And he is also alumnus from the GS Medical College and Kim Hospital, where I'm also the alumnus from that same medical school. And one of our board of directors, Dr. Gopal Malani is here, who has been 3 times the mayor of Oak Brook, which is the richest suburb in Illinois and probably richest suburb in this country. So Gopal, can you just stand up also, just so that people can recognize you? Yeah. Okay, great. So Sanjay, I'm not going to read all your biography here, which is really very, very large. But I'd like you to just look on the internet, or if you have the newspaper, look at that. But that is the best thing I can congratulate, real good service to the students from India, and very young, and real electrophysiologists. So really give a big hand to Sanjay Bindra here. All the honorees we are going to, Dr. Rakesh Sharma is going to make sure his signature looks very good. So we will be sending the awards to them through the email. And then you have to spend about $1 to get a photographic paper. Okay. And you print it out on the photographic paper and then you frame it. Okay, all right, Sanjay.
Thank you.
Sanjay, nice. And I hope your wife is doing quite well. Yes, feeling very well. Hope you're doing well. Okay. Okay. Rakesh, we have to have our president here, I can't do that without him.
Welcome and congratulations. Come right in the
Gopal, you want to come here? Yeah, come on. You are okay? Come on. Yeah. The 3-term mayor of Oak Brook, Yeah. Okay. All right, okay. I think Dr. Rakesh Sharma is going to publish a book with all the photographs. The way we have these photographs here, you'll have a whole book on photographs.
all on the website.
Yeah.
We need a Dr. Samir, please.
Okay, sure. Come on.
Dr. Samir, please. And Dr. Murthy.
Yeah, Vemuri, come on. Yeah, please come on, Vemuri. Yeah. Dr. Samir is extra. Anytime we have a meeting in Chicago, the first thing we do is to call him. And we make sure that he gets a very good place for us, just like he did today. And also where he gets a real good audience, just like he today. So congratulations, Samir.
Thank you, Samir. Really,
we never honor one of the principles we have. We never honor our board of directors. Like I have never been honored. We never honored each other. So we are not going to honor you, but still we'll honor you. Still we'll honor you. And Dr. Vemuri Murthy, we are going to honor him next time. He's not on the board, so he will get we'll honor you in the next meeting. Make sure he comes to the next meeting. That's why we are honoring him next time. So you come there, for sure.
Dr. Nanda, picture time, please.
Okay.
Hello, please, sir.
We have a photographer here, very compulsive, Okay.
Thank you.
So the next book Dr. Sharma is going to produce is photographs from this meeting. Let me go to the next honoree we have here, very important, who came here right before even we started our event, is none other than Dr. Partho Sengupta. He is actually the chief of cardiology in New Jersey, Rutgers Hospital, and also he was the chief of cardiology in West Virginia. And so I won't read all his, but he's really a very prominent person, has done a lot of work on artificial intelligence, a lot of work on very pioneering work on artificial intelligence, and also is really a very expert and well-known echocardiographer. So I won't be reading everything about him. We can see that all on the internet. So it's a really great honor for us to be here. Really great honor you could come here. I just called him many times to make sure he definitely comes here, because without him, our event would not be that good. So great to have you come here. Great. Okay, great. So, want to take a picture? Come. Let's see, who is left out here? Hanumant, ready? Come on. Who is the other board of directors member here? Dr. Dodd?
No, he's gone.
He's gone? Okay, to go. Okay, all right. Okay.
All right.
Okay.
Thank you.
Okay, now we have the young investigators. Are you all ready, guys? This is the most important event of our event here today. We honor young investigators. So all of them submit abstracts to us, and they're given, and our referees, reviewers have reviewed their abstracts and decided their abstracts were the best ones submitted. So they're all here. And one thing though, if they go exceed 5 minutes, they forfeit the $1,000 check, which we are going to give you. So make sure you don't go 1 second above. I am going to time your talks. So who is the first one here? We have Dr. Parul. Please go ahead.
Good evening, everyone. I am Parul, a first-year medicine resident at Sparrow Hospital, Michigan State University program. And first of all, thank you to American Association of Cardiologists of Indian Origin for giving me this opportunity to present here. So my presentation today is on geographical disparities in the age-adjusted mortality rates related to ischemic heart diseases in patients who suffer from substance abuse disorder, covering the data from the CDC Wonder database from 1999 to 2020. I don't have any pertinent financial disclosures regarding this study. So the aim, as I said, is basically to evaluate these disparities and how they affect these trends in various regions. Just a little background as to why is the study important at this point. So according to a 2023 National Drug Abuse Survey done, it did show that almost 48.5 million people in United States suffer from substance use disorder. And this was just over the year of 2022 and 2023, out of which above 12 years and above, 28.5 million people suffer from alcohol use disorder, whereas 27.2 million people suffer from drug use disorder, with a significant overlap between the patients. And from a cardiovascular standpoint, we are concerned because these drugs and alcohol are known to have significant harmful CV effects. And according to a very recent study in the Journal of American Heart Association, it was actually seen that the trends increased from 9.9 per 100,000 population to 21.4 per 100,000 population between 1999 to 2019. That actually represented an increase of 4% per year. What's even more pressing is the fact that the people who are affected by this actually fall into the adult age group category of 25 to 39 mainly. So this is why further going into the depths of how these death rates change over the years, especially the ischemic heart disease related deaths, is important. So we queried the CDC Wonder database that basically contains the death certificate records of the whole US population from 1999 to 2020 and consider individuals above age 15 years and older with substance use disorder whose final cause of death was an ischemic heart disease. And we stratified this data further based on the 4 US census regions, Northeast, West, South, and Midwest, and used the joint point regression system to further evaluate the annual percentage changes and the AAMR. So these were the trends that we actually observed. Generally looking at the trend, we can see that all the 4 regions had significant steep increase in the beginning up until 2004 to 2006, after which the trend started to diversify. And this diversification could be contributed by various factors, both related to the socioeconomic determinants as well as the healthcare access. In general, Midwest, South, and West regions, all 3 initially had an increase in the starting, followed by slower but still continuous increase up until 2020. Whereas, interestingly, Northeast actually showed a plateau in the death rates after 2006 and had a stable APC of 0.05%, which although cannot be said with certainty, but could be because of the saturation of the healthcare infrastructure in this region. One more thing that we see from these trends is the Midwest has actually remained an overall highest in the age-adjusted mortality trends with regards to IHD and substance abuse disorder. And West has actually remained the lowest. So this is just the overview of results that I just discussed. in conclusion, the main thing from this data that we gather is that it's a pressing need for us to have more targeted health interventions that can further identify the high-risk groups. And these interventions could be employed with regards to substance abuse prevention programs as well as healthcare access inequalities. Thank you.
I think you exceeded your time by one couple of seconds. The only way I can think of giving you $1,000 from our president is to take a vote from the. Should we give her $1,000? Please raise your hand. Okay, you are okay. Rakesh, hold on. Rakesh, please give her the award. Give her a big hug.
Congratulations on an excellent presentation. Your
Parul, I have one.
$1,000 on the way and the certificate.
Parul, I have one question. What does FNU stand for?
It's first name unknown. I have a single official name, so in US I have to use first name unknown followed by my own name Parul as last name.
Okay,
Congratulations. Okay.
Nanda, please sit down.
We're going to be hurrying up. We've got very short time.
The next awardee is Dr. Jasninder Dhaliwal. He is going to speak on differences in statin eligibility with the use of prevent versus pooled cohort equations in UK Bank, and he is from quite a few authors from different places, including Alabama, Harvard School, Boston, and Minneapolis, etc. In the meantime, before he gets ready here, can I ask Dr. Ajay Ahuja to come on the stage, please? We want to recognize one very important personality here, Dr. Ajay Ahuja. He is the medical director for AACIO, right? It's a company with hypertension. So really great honor to have you here. And hope we can work together in the future also. What do you say?
Thank you so much. I'll just take 2 minutes. My name is Ajay Ahuja. I am an American cardiologist of Indian origin, and I happen to be head of the medical affairs department for our AACIO Pharmaceuticals. I do have a 100-slide presentation that I should be able to finish in less than an hour. No, I'm kidding. I don't have any presentations, but long story short, hypertension is a very important issue. I know we all deal with it every day in our clinical lives. The majority of our patients are uncontrolled. And back in medical school, we all learned that the most potent vasoconstrictor is endothelin. But we have ACEs and ARBs and calcium channel blockers and diuretics, but there has, up until recently, not been any medicine that affects the endothelin pathway. So if you have time and interest, come by the AACIO medical booth and you can learn a little bit more about endothelin. You can learn a little bit more about how endothelin can help hypertension. And even if you have patients who are uncontrolled on ACD therapy, yet there's another modality that might help your patients. So please come by, and it's a pleasure to join you and get to know you. Thank you. Thank you.
Before I ask Jasninder to come here, one person who didn't come forward, very shy, is no other than Radhika Chimata. Radhika? Where are you, Radhika? Please come out here. Radhika, come out here, please, Radhika. Radhika is the president of the IMA, Indian Medical Association of Chicago. And this function would not have been possible unless it was just due to her really unstinted support that she gave to all of us. Radhika, can you come please over here? And okay. Okay, Jasninder, can you? Jasninder, go ahead.
Good evening, everyone. So this is a study that it's like a retrospective study that we did for the new calculator that is coming up, the Prevent calculator. So the background is that the statins has been used pretty much for the ASCVD prevention, and then there has been, the previous calculator was the PCE that calculates the 10-year risk, and then this new calculator that just came up last year was the Prevent calculator that calculated 10-year and 30-year as well as calculated the heart failure risk along with the ASCVD. So it is not in the guidelines at the moment by the AACIO, but we see that's going to be coming up forward in this year or the next year. So we try to compare the both calculators head-to-head for the 7.5% risk and to see how is the statin eligibility is changing based on the same risk thresholds. So the main problem for the the prevent was that sometimes it is known to overestimate in certain population like African Americans and in other like the older populations. It was not like a very accurate estimator for the ASCVD risk. And to just like prevent that and then have like a more wider data set. So the AHA made the prevent, which was validated in about like 6.6 million. It was derived in 3.3 and validated in 3.3 million population as compared to the PCE, which was just in 300,000 patients. So this is a comparison we did the external validation in the UK Biobank cohort as compared to, it was like never done in the external, like the PCE was on the Framingham CAM and then the other cohorts. The prevent used like all other cohorts, but the majority was the EMR data of the Optum database. So this design was a retrospective cohort analysis. We had a 261,000 patients aged 40 to 69, and then the criteria was patient must not have any ASCVD events prior to this. So in this, we tried to calculate the ASCVD risk at the 7.5% threshold, and then compared the results of the outcomes at the 10 years, because the PCE does have a limitation of only 10-year risk. So the main risk for more than 7.5% for the statin eligibility, there was in the PCE 36.9% of the population, and with the prevent there's only 14%. So as you can see, there's a drastic reduction for the statin eligibility if we use the 7.5% risk threshold with the prevent calculator as compared to the PCE, which currently used at the moment. So that basically translates to that half of the population will be losing the statin eligibility in the future if we don't change the thresholds. And according to this, the 40% are eligible for the statins and only 19.9%. There's like a 20% reduction in the whole population. And then we calculated the CS statistics, which was performed. It was 0.730, and which is like a pretty much when the prevent calculated it as compared to in their cohorts, it was more significant as in this cohort, because this is like a large, like a small cohort as compared to the prevent was much larger, so it was not translating into that. And so the risk reduction, as it is already getting reduced, so I feel like in the future, most likely the prevent is going to be applicable at the 5% as compared to 7.5%, so that they can have more equal distribution, and then the statin eligibility will not be affected that much. Yeah, that's it. Thank you.
That was very good. Jaswinder, what are you going to go with the $1,000 that our president is going to give you?
Tomorrow.
Yeah. So you are in Birmingham. You have to take me to dinner, huh?
Sure.
Okay.
Yeah. Thank you very much.
The last but not least, we have Dr. Priyanshu, who is another winner of the Young Investigator Award. Disparities in diabetes-related outcomes in prostate cancer patients, role of social determinants of health and race. Some of the young investigators who have had our award in the past have risen very high. You all know Deepak Bhatt. He got Young Investigator Award many years ago. So hopefully all of you would actually make us very proud by rising up in cardiology, okay? Okay.
Thank you so much for the warm introduction. I am Priyanshu Nayan. I'm PG by 1 at Advent Health Redmond in Rome, Georgia program. Also a postdoc research fellow with Guha Lab at Medical College of Georgia at Augusta University. I'm going to present my presentation on disparities in diabetes-related outcome in prostate cancer patients with a special focus on social determinants of health and race. So a little background, cardiovascular mortality has now surpassed the prostate cancer mortality. The cardiovascular mortality is the most common cause of death in prostate cancer patients. And the impact of pre-existing diabetes mellitus in these patients is very unclear. Adding on to the complication, androgen deprivation therapy and with pre-existing diabetes mellitus. Thank you so much. That's why he's my mentor. Adding on to the complication, the androgen deprivation therapy that these prostate cancer patients get with pre-existing diabetes mellitus, this could also lead to the worsening of outcomes directly and indirectly by decreasing the glycemic control and development of metabolic syndrome. A little background about how metformin works. Metformin has been shown to have anti-neoplastic activity in prostate cancer patients. It mainly acts by two mechanisms. The first is to increase the AMPs to AT ratio, and the second is by decreasing the PI3K and mTOR signaling, which has been shown to inhibit cell growth. The objectives of this analysis was to analyze the relationship between diabetes and cardiovascular outcomes in prostate cancer patients. And another second objective was to analyze the diabetes medications in prostate cancer patients who received androgen deprivation therapy. For this, we used SEER Medicare link database. Our study population was majorly males who were 66 years or older with a new primary diagnosis of prostate cancer who underwent ADT treatment between the years of 2009 and 2017. We created two cohorts. The first cohort was created to see the effects of diabetes on the outcomes, cardiovascular events, cardiovascular mortality, prostate cancer mortality, and all-cause mortality. We created another cohort to see the effects of metformin and the other diabetes medications, specifically on the patients who received ADT. We used Cox proportional hazard models and fine and gray methods to calculate the adjusted sub-hazard distribution ratios for our outcomes. A little baseline characteristics of our first cohort. We included around 150,000 prostate cancer patients. 32% were diabetic at the baseline. The median age was around 72 years, and around 78% of this cohort was non-Hispanic white patients. Diabetic patients were a little older and were more likely to identify as non-Hispanic blacks as compared to non-diabetics. Patients with diabetes also had living in the areas of low socioeconomic status and living in the areas of high school or above education. Diabetics were also likely to have a prostate grade of 3+. They were also likely to have other comorbidities, specifically hypertension, CKD, and hyperlipidemia. Patients were followed from prostate cancer diagnosis until the end of year 2019, and we reported outcomes for a median follow-up years of 3.2 years. Diabetics specifically have a higher CVE rate across the border, higher heart failure, higher atrial fibrillation as compared to the non-diabetics patients. We can see that among the subclasses of non-Hispanic blacks, lower socioeconomic status and lower education living areas, there were higher all-cause mortality, higher CV events and CV mortality, but that was not seen with the prostate cancer mortality. I am going to skip the baseline characteristics of cohort 2, but just a quick overview. We included 14,000 patients for prostate cancer who received ADT as well. And we saw that the patients we followed them, and we saw that the patients who were diabetics and on metformin had a significantly lower cardiovascular event rate. We also demonstrated that they have a significantly lower all-cause mortality, but the results were not significantly lower for prostate cancer mortality, cardiovascular events, and cardiovascular mortality. In conclusion, diabetic prostate cancer patients had worse outcomes in terms of cardiovascular events, cardiovascular mortality, and all-cause mortality, especially those living in the low education and low socioeconomic areas. And in the second cohort of patients who received ADT treatment, we saw that the prostate cancer patients who were receiving metformin, they had significantly, who were not receiving metformin had a significantly higher all-cause mortality as compared to those taking metformin. I would like to acknowledge Dr. Guha for his mentorship. Thank you.
You have to learn to be short and sweet. Rakesh?
When Dr. Nanda stands, you probably got stressed out, but you did good. Your check and certificate would be in the mail. Thank you. Go ahead.
Oh. Radhika, can you please come here and be recognized? We looked for you in a while, but Rakesh, come. Radhika, we want to really thank you very much. You are really the pillar behind this event we had today, the success of the event. We are household here. We really want to congratulate you very much and thank you so much. We are so grateful to you.
A lot more next March coming up. The bigger meeting is going to be bigger than that. Thank you.
And we want to thank the audiovisual team here. They did a great job. And also the photographer did a great job too, Okay. Thank you so much. Okay. Oh, okay. Okay, either. Come in the middle. Come in the center.
There you go. It's done. Madam, please come. Thank you.
Thanks a lot.
All right, Dr. Nanda, thank you very much for conducting this excellent program. Guys, there would be only 2 more minutes because I know that you're all looking for dinner, and I really appreciate you, the patience. There was excellent lectures. I want you to give a big round of applause, Dr. Puri. It was such a great lecture on lipidology. I tell you, I heard many lipidologists. The way you cover stuff in your slides is amazing. Dr. Shah, stand up for, he has done a wonderful work for putting it all together. And the bigger meeting is coming up soon, which is in March 29th. And it's going to be bigger than that. We're expecting 3 times bigger than that. Before I conclude, there's one surprise award. But I want to call Dr. Mamuri Murthy here on the over here. He is a past president of IMA. He's associate professor of University of Illinois. He's a current chair of Board of Trustees of Chicago Medical Society. He's been quite instrumental in putting this all together. He has some surprise award for somebody. Thank you.
Dr. Nanda, you can control my time. Let me take half an hour. I'm so proud. This is the moment I've been waiting for the past 30 years. Actually, this is my 3rd win. I was a general surgeon. I was an anesthesiologist. Now I'm a professor of emergency medicine. But the core of my heart has been the American Heart Association. I've been serving the American Heart Association for the past 37 years, including as the national and international faculty. And my relationship with Dr. Naveen Nanda can be traced back to more than 2 decades. A man of supreme command in cardiology. And I was truly blessed. And this is the moment I've been waiting for a long time, Naveen. He actually, we go a long way from the viewpoint of the cardiac arrest. And we brought the first registry of out-of-hospital cardiac arrest, which has won an international award. And we have been working non-stop, about the out-of-hospital cardiac arrest, cardiac registries, and more importantly, about the associated, long COVID and all that. Thanks, Naveen, for giving me this opportunity to be with you. I don't have a lot of mentors. I got only one mentor before I came to India. Even though I'm not a cardiologist, so he is, I'm his non-cardiologist, cardiac research mentee. So, and I will tell you, this comes from our heart. When I talk to some of the past presidents of the Chicago Medical Society and also the Indian American Medical Association, so we thought that this is very appropriate and very timely, and it's very important to recognize when somebody gets an award, it's not for him personally. It is for the work. It is for the devotion. It is for the engagement. And Dr. Naveen Nanda was not born yesterday. And he has so many accolades. I don't want to mention that. Maybe, I don't know, maybe you're living in the midst of about 300 to 400 international awards. So, to keep it short, today, we are all here gathered here from the American Association of Cardiologists of Indian origin, the local leadership of the Indian American Medical Association, Illinois, today represented by the 2nd generation president, Dr. Radhika Chimata, and also, of course, my peer, my colleague president from the Chicago Medical Society is not here. So I, as a past president of CMS and current chairman of the Board of Trustees, so I'm taking the burden of representing him too, I request all the past presidents and the president-elect of IAMA Illinois to come here, please. And also the executive committee and the board of trustees, or board of directors of the AACIO here, and the trustees, the past presidents of the Chicago Medical Society, represented by the Lone Ranger here today. So we are all here, please come here. Now we are going to recognize a man, an outstanding man, a very humble, outspoken, and he is truly the father of modern echocardiography, Dr. Naveen Nanda. I want all the AACIC honorees and all the eminent speakers, please come and join us. Doctor, we'll take care of it. I know you're excited. So, we have the opportunity of, having interacted with him for so long. And it is really a proudful moment. So, I'm going to, please, those of you who are all here, Gopal, please come here, please, too. Yeah. And the Chicago Medical Society, incidentally, it was founded in 1850. And also the Indian American Medical Association of Illinois, which was established around 1709 or so. We recognize Naveen C. Nanda, MD, DSc, as father of modern echocardiography for his decades of iconic contributions to echocardiography. And it is signed by me as the chairman of the board of trustees, Dr. Tariq Butt as the current president of Chicago Medical Society, Dr. Radhika Chimata, president of the IAMA, and we all very proud. And actually we are proud and we share our joy and pleasure with all of you to present this commendation to the greatest living legend of cardiology, namely Dr. Naveen C. Nanda, my mentor and your mentor. Thank you.
Okay. Hello. Picture time. Can you come here, please?
I know you guys have parked here. We promise that we'll reimburse your parking. If anybody want money for your parking, meet Dr. Samir Shah. He will take care of you.
Just one comment. First of all, I'm really humbled and honored by this award. But I just have one comment, really, the good thing is I don't have to spend any money to make a plaque of my award. You already did that. Thank you so much, Thank you. Going for dinner now, huh?
No, the parking. So those who have parked in the next door, AACIO and Rakesh has graciously decided to pay for it. So all you have to do is to bring your voucher to me and I will sign it. And when you go there, please don't pay any money because we'll pay when you're all done. Okay? Thank you. I'm here on this table. Thank you.
Doctor, please.
Thank you guys. While you're getting to the food, I would like to make few more comments. As you know, American Association of Cardiologists is growing and we have a brand new website. In fact, we'll invite you all to become a life member and the life membership is $500, but it is discounted to $50. $50 will go a long way for anytime you even come for one dinner, it gets paid off. So please become our life member. That is very important to us. Oh, yes. And I do want to recognize one more person. Ravindra, can you come here? There's one unique person who has been behind this development of website. He's our board member, Dr. Ravindra Bhardwaj. He is a cardiologist actually in India and he's excellent, very hard worker. We appreciate you. He's ongoing basis. He's watching, he's collecting your all data. He's going to upload all these pictures on your website. You'll get to see it. But we really appreciate you. Thank you. Come here. We'll get a picture with Dr. Nanda.
Hello, sir. Sir, please. Sir, please come.
Thank you. Thank you. Thank you very much for the hard work. Thank you.
Thank you, everyone. So I might not be a cardiologist, but I'm here to sing for you. So actually, I'm a psychiatrist. Just want to say that out loud so you all know. Full disclosure, I'm a psychiatrist. I'm not a cardiologist. Thank you for having me at your meeting today. And of course, I'm here, as I said, because I'm part of the Indian American. We have all sorts of everything happening, and it's a wonderful networking opportunity. I hope to see you there. So earlier, I know we were recognizing and thanking the folks who have given you the sound for tonight. So I just want to go ahead while we're pulling up the next tune. I want to let you know about the folks who have given you the sound tonight, without which we are nothing. So give a round of applause to Mr. Amit Patel. Amit Patel. You're so welcome. Amit Patel, along with folks who are supporting him and helping him out. That would be Mr. Deepak Bhai Shah. Give it up for Deepak Bhai. Oh, my goodness, I'm so sorry. Deepak Bhai Patel. Sorry about that. And of course, Jitu Balsara. He's around here too. Big round of applause. All right. So we cleared out this area here for you folks. So you can dance. So you can come and dance with your partners. Those of you who came with your partner, come on up here and dance. Those of you who don't have a partner, grab one and come on up here and dance. जो भी है
यही वक्त है कर ले पूरी आरज़ू आगे भी जाने न तू पीछे भी जाने न तू जो भी है बस यही ऊपर है आगे भी जाने न तू
Ladies and gentlemen, I'm looking for the dancers and I'm looking for the requests. If you have a request, come on over and let Amit know. Amit is the sound engineer. He controls everything and I'll be happy to try to fulfill it.
इस पल के साए में अपना ठिकाना है इस पल के आगे भी हर शय फसाना है कल किसने देखा है कल किसने जाना है इस पल से पाएगा जो तुमको पाना है जीने वाले सोच ले यही वक्त है कर ले पूरी आरज़ू आगे भी जाने न तू पीछे भी जाने न तू जो भी है बस यही पल है
Thank you. Now I'd like to bring on another amazing singer. I think most of you probably already know him, but I'm going to introduce him anyway. So he's going to be co-performing with me tonight. His name is Rajesh Chalam, an amazing singer. He's been singing in the Chicagoland area for quite a number of years now, and I really appreciate him joining me tonight.
Thank you so much, Radhika. It's really an honor for me to sing here. And as Radhika said, I've been honored and I've had the pleasure to always perform for her programs, be it API, be it AACIO. Did I pronounce it that right?
You got it.
Okay, so let's start with one of the most prominent songs, one of the most super hit songs from the movie Yadon Ki Barat, which is again one of Radhika's favorite songs. So let's start with that. So this was composed by the legendary R.D. Burman, sung by Asha Bhonsle and Mohammad Rafi.
चुरा लिया है तुमने जो दिल को नजर नहीं चुराना सनम बदल के मेरी तुम जिंदगानी कहीं बदल न जाना सनम हो लिया दिल हाय मेरा दिल हाय दिल लेकर मुझको ना बदलाना चुरा लिया है तुमने जो दिल
सजाऊंगा लुट कर भी तेरे बदन की डाली को, लहू जिगर का दूंगा हंसी लबों की लाली को। सजाऊंगा लुट कर भी तेरे बदन की डाली को, लहू जिगर का दूंगा हंसी लबों की लाली को। है वफा क्या इस जहां को, एक दिन दिखला दूंगा मैं दीवाना। चुरा लिया है तुमने जो दिल को, नजर नहीं चुराना सनम। बदल के मेरी तुम जिंदगानी, कहीं बदलना जा सनम। ले लिया दिल हाय मेरा दिल, हाय दिल लेकर मुझको ना बहलाना। चुरा लिया है तुमने जो दिल को, नजर नहीं चुराना सनम।
Thank you. Thank you so much. Let's have a faster one. And as Radhika said, we can take more requests and we can sing faster songs, dancing songs. So please let us know.
छुप गए सारे नजारे, हाय क्या बात हो गई। छुप गए सारे नजारे, हाय क्या बात हो गई।
तूने काज बात हो गई, तूने काजल लगाया दिन में रात हो गई। मिल गए नैना से नैना, ओए क्या बात हो गई। मिल गए नैना से नैना, ओए क्या बात हो गई।
दिल ने दिल को पुकारा, मुलाकात हो गई। दिल ने दिल को पुकारा, मुलाकात हो गई।
कल नहीं आना मुझे न बुलाना, के मारेगा ताना जमाना। कल नहीं आना मुझे न बुलाना, के मारेगा ताना जमाना। तेरे होठों पे रात ये बहाना था, गोरी तुझको तो आज नहीं आना था। तू चली आई दुहाई, ओए क्या बात हो गई। तू चली आई दुहाई, ओए क्या बात हो गई।
मैंने छोड़ा ज़माना, तेरे साथ हो गई। मैंने छोड़ा ज़माना, तेरे साथ हो गई।
ओ तूने काजल लगाया दिन में रात हो गई।
सावन आने का कुछ मतलब
तेरी चुनरी लहराई बरसात हो गई, तेरी चुनरी लहराई बरसात हो गई।
दिल ने दिल को पुकारा मुलाकात हो गई। छोड़ो न पैया पड़ो तेरे पैया तारों के छैया में सैया। छोड़ो न पैया पड़ो तेरे पैया तारों के छैया में सैया।
एक वो दिन था मिलाती न थी तू अखियां, एक ये दिन है के जागी सारी सारी रतियां। बन गई गोरी चकोरी ओए क्या बात हो गई, बन गई गोरी चकोरी ओए क्या बात हो गई।
जिसका डर था बेदर्दी वही बात हो गई। वो जिसका डर था बेदर्दी वही बात हो गई। छुप गए सारे नजारे और क्या बात हो गई।
दिल ने दिल को पुकारा मुलाकात हो गई। अजी ऐसा मौका फिर कहाँ मिलेगा, हमारे जैसा दिल कहाँ मिलेगा। आओ तुमको दिखलाता हूँ पेरिस की एक रंगी शाम। देखो 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 an evening in Paris। अजी ऐसा मौका फिर कहाँ मिलेगा, हमारे जैसा दिल कहाँ मिलेगा। आओ तुमको दिखलाता हूँ पेरिस की एक रंगी शाम। देखो 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 देखो।